am Dr. Ashna MDS, Department of Prosthodontics, Assistant Professor in Vinayaga Mission Dental College. I will be taking on the topic temporization or provisional restoration in FPD. The contents will be definition, ideal requirements of a provisional restorative material, their classification, requirements, and provisional restorative materials different types, steps in fabricating provisional restoration, recent advances in provisional restorative material, cements used for luting provisional restorations, removal of a provisional restorative material, their limitations, conclusions, and at last it will be reference. Moving on to the definition, temporization is nothing but a fixed dental prosthesis which will have aesthetic stabilization and function only for a limited period of time, after which it has to be replaced by a definitive prosthesis. So, only for a short duration of time we will be using a temporary restoration, after which it is replaced by a definitive prosthesis. So, these provisional restorative material will have certain ideal requirements which will fulfill the biological, mechanical and aesthetic properties. The biological properties will be pulpal protection, periodontal health, positional stabilization, prevention of fracture and occlusal harmony. The mechanical requirements will be functional, retention and removal of, and it should be easy to remove. Aesthetic requirements will be shape, size, color, texture, color stability, and it should serve as the guide for permanent restoration. Moving on to classification, provisional restoration should be classified based on certain headings. First will be based on the method of fabrication, they are classified as prefabricated or custom made. Based on the materials used, they are classified as resin based or metal based. Example for resin based will be again prefabricated, custom made. Metal, it will also be classified as prefabricated and custom made. We will be discussing in detail in the further slides. According to the duration of usage, it can be short term or long term provisional restorative material. According to the technique of fabrication, it will be classified as direct technique, direct and indirect technique, which is a combination. So, requirements of a provisional restorative material, it should have adequate strength, wear resistance, biocompatibility, dimensional stability, and it should be easy to contour and polish. It should be odorless and it should be compatible with the luting cements. It should have ideal aesthetic properties and it should have working and setting time. It should also be easy to repair. So, first will be acrylic temporary restorative material, which we commonly use in our clinical cases. So, it will be available in both powder and liquid state. It can be used for either single or multiple unit restoration. The advantages will be low cost, easy to manipulate and easy to repair. The disadvantage will be polymerization shrinkage, odor, exothermic reaction because heat is produced during the setting of these acrylic and it is hard to repair, and radiolucency are the disadvantage. Moving on to next temporary restorative material, it is nothing but bis acrylic composite and various shades are available and it will be available in various shades and it will be used by using a cartilage. The advantage will be less shrinkage when compared to that of the acrylic restorative material, minimal heat generated than compared to that of the acrylic, and it will be having an excellent aesthetic properties, easy to repair and trim, color stability and radio opacity. Disadvantage will be its cost because it is expensive than the acrylic restorative material. Viscosities cannot be altered, more brittle, and the material wastage because of using in a cartridge system. Next will be polycarbonate crowns. They are nothing but material made of microglass fibers with polycarbonate plastic materials. And here we have to reline the material with acrylic resin so that it properly fit into that of the prepared tooth. Only single shade is available. The shade of the provisional restoration is based on the lining resin which is inside that of the shell. And it is available for incisors, canines and premolar and not for molars. Next will be cellulose acetate. They are nothing but thin transparent scaffold. It is available in all tooth shapes and different sizes. We have to reline it with a relining resin material. Then after it is set in the patient's mouth, we have to peel off the shell which is transparent. Next is aluminium and tin silver. They are used for posterior restorations, and they mimic the anatomic form of a tooth. There will be good adaptation because the material is more ductile, and they easily wear off, and there are perforations seen on these crowns, and they cannot be used as a long-term provisional restoration. Relining of these crowns will enhance the fit of the crown. Next is nickel chromium. They are indicated in children with severely damaged teeth, and no relining is required. It can be trimmed, contoured and adapted easily, and we need a strong cement to lute them so that it can be used as a long-term provisional restoration. Steps in fabricating temporary restoration. So there are three techniques: direct technique, indirect technique, and combination of both the direct and indirect technique. Direct technique, the restorations will be fabricated directly in the patient's mouth. So indirect technique, you will be fabricating the restoration in the cast and then placing it in the patient's mouth and checking the fit and cementing it. Next is direct indirect technique. In this technique, the restoration are fabricated both in combination of the above said two techniques. So first, moving on to direct technique. I said earlier, the restorations are fabricated directly in the patient's mouth after tooth preparation. So the advantages will be, it consumes only very little time, the cost is also less, and no need for making cast. The disadvantages will be, it will be useful only for single unit restoration and very short span bridges, and patient cooperation is very much required because setting reaction will produce exothermic heat which cannot be tolerated by the patient. It will cause injury to the gingiva also. So first, direct technique, we will be seeing the steps by using polycarbonate provisional restorative material. So first, the teeth mesiodistal width is measured. After that, the prefabricated or pre-customized crown is selected based on the mesiodistal width. Then we have to trim the excess in the pre-selected crown. After that, it is fit is checked in the patient's mouth and it is cemented using a temporary restorative material. Next, direct technique using a custom-made provisional restorations by using the index to fabricate it. In this picture, there is missing maxillary central incisors. We are constructing an RPD for the patient and we are making putty index with the RPD intact. After that, we have to remove the RPD, place resin matrix resin into the indentations in the putty impression, place it in the patient's mouth. We will get the provisional restoration in place in position with that of the patient's mouth. After that, it is taken out and trimmed and cemented to the patient. The next will be indirect technique. Here the restoration is fabricated extraorally in the cast. So the advantages will be, patient cooperation is not much needed. Patient's time is saved because we fabricate the crown laboratory side, not in the chair side. And disadvantages will be, we are making an extra impression for fabricating a provisional restoration and it is costly also. So the steps will be, we have to first select a prefabricated crown. Here nickel chromium crown has been selected. Then after that, we have to trim the excess contours by using a plier. Then we have to polish the contours. Then we can adapt the contours by using a plier so that it fits directly and has a passive fit with that of the crown. And we have to check the occlusion. This is another example for indirect technique using a template. First, in the cast, we are just arranging the teeth by using artificial teeth. Over that, we are using an Wacom template and making a template for the restoration. We are removing the template and we are doing a tooth preparation in the cast. After that, the template is placed and the fit is checked in the cast. In the intaglio surface of the template, we are placing the temporary restorative material and the template is seated onto the cast and we get a temporary restoration that has to be checked, trimmed in the patient's mouth and finally cemented in the patient's mouth. Next will be direct and indirect technique. So this is a combination of both the techniques. We use both patient's oral cavity and the cast for fabricating a temporary restoration. So here a shell is fabricated using the cast and over that in the patient's mouth we are adding acrylic resins or a provisional restorative material. We are relining it, placing it in the patient's mouth and fabricating a final restoration. So first, we are taking the impression, pouring the cast. We are doing a dummy mock preparation in the cast. Over the cast, we are placing a putty and taking an index. After that, a restorative material is placed on the putty index and it is secured on the cast until the material sets. After that, a restorative material is taken out, excess is trimmed, and the fit is checked in the patient's mouth. After teeth preparation, the inner surface of the temporary restoration is lined with an acrylic resin and directly it is placed in the patient's mouth and it is cemented after the checking of fit and occlusion. So, recent advances in provisional restorative material. So, recently CAD/CAM milling of provisional restorative material is more advantageous and there are precise fit on many studies compared to that of the traditional method of fabricating and CAD/CAM method of fabricating a provisional restoration. Next is the integrity temp. It is nothing but high impact composite used as a provisional restorative material, which is indicated for long term provisional restoration. Next is rubber based urethane materials, which can be also used as a temporary restorative material. So, moving on to cementation of temporary restoration, there are certain cements which is indicated for luting a temporary restoration: zinc oxide eugenol, reinforced ZOE. Here we are advised to use non-eugenol cements when a resin cement is fabricated, because eugenol will react with the resin cement, so that the reaction is compromised and the fit or the strength of the restorative material is lost when using a eugenol cement and a resin cement for permanent restoration. So, how to remove a provisional restoration? It is easy to remove provisional restoration because we use a temporary cement to lute it. So, the forces which we give on removal should be parallel to that of the long axis of the teeth preparation. If it is a single unit restoration, we can easily remove by using a hemostatic artery forceps. The moment which we give for removal is buccolingual movement for a single unit restoration. If it is an FPD like 3 unit or 4 unit, a floss is tied in, underneath the connector and a pull is given so that the restorative material is removed. Sometimes crown removal can also be used if the cement is tightly fit in the teeth. The limitations of a temporary restorative material will be, it does not have adequate strength, so fracture is more commonly seen, and inadequate marginal adaptation is also seen. Poor aesthetics, plaque accumulation, and bonding is compromised, and tissue irritation is common in temporary restorative materials. So, to conclude, we have to choose a proper temporary restorative material and temporary luting cement for a success of a temporization. So, there should be a thorough knowledge on advantage, disadvantage of the temporary material available and indication of each temporary restorative material. So, we have to give a temporary restorative restoration to safeguard the tooth until a final restoration is provided. So, these are my references from Rosenstiel, Schillingberg, Deepak Nalasamy and Rangarajan. Thank you for watching my class.